So I want to welcome everybody to today's Family Medicine Grand Rounds. Today is July 28th, 2021. For those of you claiming CME credit for today, your code is 209047. And you'll want to make sure that you do claim that credit before midnight tonight. I posted earlier in the chat box the link if you need that, but I'll be posting again the code and the link here in just a moment. But please make sure that if you do need that, you do that before midnight tonight. Next slide.
Sorry.
That's okay.
I don't know why the button's not working now. Okay. Okay.
There we go. All right, so we want to thank everybody as we get started here. We are doing a virtual presentation today, so if you would please make sure that your microphone is muted as we get started. Please remain attentive and engaged in the session. I will also be putting in the chat box towards the end of the presentation the evaluation link. So if you can help us out with that, our presenter has mentioned that she is okay with questions during the presentation, so you're free to put those in the chat box as we move along. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC, and you can see our department's mission statement listed there for you. CME transcripts are available at the CME website. If you go there, you are able to look up the past sessions that you've attended. You will need that if you are looking into getting AAFP credit as well. That should be coming up here on the next slide. So those who are also interested in the AAFP credit, the information is listed there, but if you're having trouble with either the CME or the AAFP, please feel free to reach out to either of those two entities, or you may also reach out to myself, Nicole Rubio. Next slide. And so we do want to make sure that we do point out to you that it is the goal that all of our FCM Grand Rounds presentations address the following nationally established physician core competencies, and you can see those listed there, but if you have any further questions, just let us know. And Dr. Nguyen and her preceptor, Dr. Montañez, have no financial relationships with ineligible companies to disclose for this presentation. And today she is going to be talking to us, Dr. Clare Nguyen. She's going to be talking to us about acute low back pain. She is being precepted by Dr. Montañez, so I will let her get started with her presentation.
Hi, everyone. Thank you, Nicole, for starting the presentation and for the introduction. I'm one of the PGY3s in family medicine here at UT San Antonio. My preceptor for today is Dr. Montañez, and the topic that we were discussing today is acute low back pain. It's based on an article that that's titled A Randomized Placebo-Controlled Trial of Ibuprofen plus Metaxalone Tizanidine or baclofen for Acute Low Back Pain. And I do want to thank Dr. Montañez for helping me edit this presentation today and for the feedback, and also Dr. Cruz and Dr. Ferrer for making another revision to the presentation. They were all really helpful. The objectives for today is to discuss the effectiveness of ibuprofen plus placebo versus ibuprofen plus one of three muscle relaxers, baclofen, metaxalone, tizanidine, 1 week after patient going to the ED visit for acute low back pain. We're also going to discuss the first line treatment for acute low back pain and apply the results to a primary care practice. The point of the presentation today is to do patient-oriented evidence that matters, or POEMs. Many of us will be doing this throughout the year. The POEMs are summaries of research relevant to patient care that meets three criteria. One, they address a question that primary care physicians face. Two, they measure the important outcomes, including symptoms, morbidity, quality of life, and mortality. And they have the potential to change the way physicians practice. So this study, again, it's based on a randomized clinical trial of patients being treated for acute low back pain with either ibuprofen plus placebo, which is the control arm, versus ibuprofen plus one of three muscle relaxers, which is the investigational medicine in this study. It's a randomized, double-blinded study. Patients who came to the ED for acute non-radicular, non-traumatic musculoskeletal low back pain. They're followed up by telephone at 2 and 7 days for assessments, and they were done at 2 academic emergency centers at Montefiore Medical Center in New York, which are large. It's a large academic center. They included adults from age 18 to 64. They had to have low back pain for less than 2 weeks, therefore acute low back pain, not chronic. They had to have functional impairment from the acute low back pain, which is defined as a score of greater than 5 on this Rowland-Morris Disability Questionnaire. I'll describe more about the questionnaire, but it's a survey of like 24 questions that helps to quantify how severe their back pain is in terms of functional impairment. And here is the Rowland-Morris Disability Questionnaire. For the rest of the presentation, it will be abbreviated RMDQ on the presentation and in the data tables presented. And here's a set of these questions. Example, I stay at home most of the time because of the pain in my back. I walk more slowly than usual because of the pain in my back. I only stand up for short periods of time because of the pain in my back, etc. We could go through the rest of them, but I think for the sake of time, I won't be doing that. A score of 0 is no back pain. A score of 24 is a severe functional impairment due to the pain. And like I said, a score of greater than 5 is necessary to be included in the study. So the participants in the study were enrolled from May 2017 to July of 2018. They were 1,355 were assessed for eligibility in the for the study, and then of those, 1,028 were excluded for various reasons. For example, their pain was over 2 weeks. They had radicular pain because this study is based on non-radicular pain. They had frequent back pain. They had trauma, age, over 64. So amongst the ones that they were pregnant, amongst the ones that met the criteria was 320. And they were divided into 8 groups of 80. The 80 was allocated to placebo, which is the ibuprofen and the placebo tablet group. They were allocated the baclofen, which is ibuprofen plus investigational muscle relaxer baclofen. And then the other 2 groups is ibuprofen plus another muscle relaxer, metaxalone. And the 4th one is ibuprofen plus tizanidine. And among all of them, they had a few that were lost to follow-up, as you can see, not very many. Overall, they had about the same in 70-something participants, which is about the same total in all groups. And so they were randomized to be treated with 1 of 4 medication regimens, and they were provided with a 7-day supply of the medication. The control group was ibuprofen and placebo. They received ibuprofen 600 milligrams plus the placebo pill Q8 hours PRN. And the baclofen group received ibuprofen plus baclofen 10 to 20 milligrams, 10 Q8 hours PRN. Metaxalone, ibuprofen plus metaxalone 400 to 800 milligram Q8 hours PRN, and the tizanidine, the ibuprofen plus tizanidine 2 to 4 milligrams Q8 hours PRN. So each of these investigational medicine for the muscle relaxers, they had 1 tablet that they could take that were 10 milligram of baclofen, for example. They could take 1 to 2 tablets every 8 hours if they wanted. So if they could take an additional capsule of the muscle relaxer if they felt no relief within 60 minutes of taking 1 capsule. And the pharmacist did the randomization of the medications. So the ibuprofen was not masked. Everyone knew the ibuprofen medication bottle, but the placebo and the 3 muscle relaxers, they were masked to all people involved. Only the pharmacist did the randomization. So it was a double-blinded randomization study. And each participant was also given a 10 minutes education on back pain as well. Methods, again, we use the Roland Morris Disability Questionnaire to measure how their back pain affected their functional impairment. They recorded the baseline characteristics of the participant, including their age, gender, work status, the baseline score, the duration of their low back pain, and the presence of whether depression was there. And here is a table describing the baseline characteristics of all 4 groups. Noticeably, you could see, I highlighted all the ones in yellow that I thought were kind of stood out to me when I looked at it. The baseline characteristics, there were more men than women, 55% in the placebo group, 71% in the baclofen, 55% in the metaxalone, and 53% in the tizanidine group. Also, work status, most people worked more than 80 hours per week. As you can see, 81% in the placebo, 79% in the baclofen, 75% in the ibuprofen, the metaxalone, and 85% in the tizanidine group. Also, the majority, the median disability score at the ED visit was about the same for all 4 groups. And when they did the baseline disability score, it was about a 20 for the placebo, 20 for the baclofen, and 18 for the metaxalone, and 19 for the tizanidine. And as you can remember, 24 is the max impairment. So they scored pretty high on their acute low back pain. The median duration of their low back pain before coming to the ED was about 72 hours for the placebo group and 72 hours for the baclofen group, but noticeably only 48 hours for the metaxalone and 48 hours for the tizanidine group. The number of people who reported previous episodes of low back pain, a majority said a few, about 65% to 50s and high 50 percentile for all 4 groups. And the majority said they had only a few reported positive depression screen, 4% in the placebo, 3% in the baclofen, and 5% in the metaxalone, and 4% in the tizanidine group. So that depression was unlikely to be a factor in their back pain. So outcome, the primary outcome of the study was to assess the improvement in the disability score from the initial ED visit to 1 week later score. And secondary outcome was to assess the severity and the frequency of the back pain at 48 hours and 1 week after the ED visit. And they also wanted to see the need of medication for the low back pain at 48 hours and 1 week, and see the time to return to usual activities during that 1 week, as well as measure the adverse effects of the medication and assess if they had any other visits to outside healthcare providers during the 1 week of their back pain. So here's these next 2 tables. This one is the 48-hour outcome table, and this one is the 1 week outcome. So I'll kind of flip back and forth between so you can see the difference between them. At the 48-hour outcome, the majority said they reported their pain as moderate to severe, as you can see, 62% in the placebo, 48% in the baclofen, and 55% in the metaxalone, and 47% in the tizanidine. But at the 1 week outcome, majority reported mild to none in terms of the severity of their back pain. 70% in the placebo, 60%, 67% in the baclofen, 63% in the metaxalone, and 67% in the tizanidine group at 1 week. So their pain did improve for many of them. And then back to the 48-hour outcome, the number who said frequency of low back pain as never, rarely, sometimes, frequently, or always. Most of them said sometimes and frequently or always in reporting the frequency of low back pain during the 48 hours after the ED visit in the 30 to 40 percentile if you go across the numbers. And then in terms of the frequency of the back pain reported at 1 week outcome, you see a higher number of people saying never, rarely, or sometimes instead of the frequently or always. So there was an improvement in the back pain at the 1 week outcome. And then the use of medication for low back pain during the 24-hour before the 48-hour follow-up. Most people reported using medication during those 48 hours, 94 percentile in the placebo. There were 91 percentile in the baclofen and 91% in the metaxalone and 90% in the tizanidine. And here you can see the number of people who said no medication at 1 week follow-up in the 24 hours before the 1 week follow-up. There is more people now saying no medications were used by that time, about 37% in the placebo, 38% in the baclofen, and 36% in the metaxalone, and 37% in the tizanidine. And in terms of the number of people who said they used medication in the 24 hours before the 1 week assessment, the number had dropped from the 90-something% to in the 60s percentile. And then the number of people at 48 hours who resume work or usual activities, they're about 30%, 30 to 40% reported they resumed work at 48 hours, but the majority said they had not resumed work yet. And as you can see over here, the median days until they resumed usual activities was about 2 for the placebo group, and 4 days for the baclofen, and 3 for the metaxalone, and 3 for the tizanidine. Of note, they did report that greater than 25% of the patients had not yet returned to usual activities before a 7 days follow-up in the baclofen group specifically. And what's also important to point out is that they measured the difference in this. They also measured the mean improvement in the disability score between the baseline ED visit and the 1 week follow-up. And the difference between the score was about a 10 to 11 across the board, all 4 groups, that their score decreased about 10 to 11 points from that survey. And so their functional impairment improved by that many, but they did the 95% confidence interval for the difference between the placebo and baclofen, placebo and metaxalone, and placebo and tizanidine group. And it was not statistically significant because, as you can see the numbers down here, they crossed 0 from like minus to a positive. So what that kind of implies is that the difference between them was not statistically significant, even though they did have about the same number of decrease in terms of their improvement in functional impairment. This is another table showing the data results. This is a box and whisker plot from the ED visit to day 7 assessment. And the 0 to 24 is the disability scoring that they received. As you can see, the score decreased for all 4 groups from ED visit to day 7. They all went down for all 4 groups. So they had, for the majority, they did improve. The middle horizontal line is the median, which is the middle value of the data, and the box and whisker box plot in the middle is the interquartile range, which is the middle 50% of the values data. And this chart is displaying all the data scores from baseline to day 7 follow-up. So for the majority of the scores, they went down, most of them, although some didn't go down enough to see an improvement. As you can see here, they started around like a nearly 24, and they only went down to maybe in 17 or 18. So not everyone has that not everyone's back pain resolved at 7 days. They still had a pretty moderate back pain at 7 days. And some people's back pain actually score went up on the few that trended up as well. So their back pain actually worsened at the 1 week. This is a table. One of the secondary outcomes they measured was to see if the patient went to see any other healthcare providers during that 1 week after the emergency room visit. A large number, or most of them, went to see primary care, 8 in the placebo group, 1 in the baclofen, and 3 in the metaxalone, and 4 in the tizanidine group. Other people they saw was an MD specialist, like a spine surgeon, pain management, physical therapy, complementary therapy, such as massage. So, but for the majority, most of them didn't really go see another provider after in that 1 week. So they also assessed the adverse effects of the medication. They said that most of the adverse effects were minor, nothing was serious in the ones that reported adverse effects. And most of them had no adverse effects in the 93%, 90%, 91%, and 92%. Of note, it looks like they had 13 missing data in the placebo group, though. And let's see. The limitations of this study, though, was that it was conducted in 2 urban emergency department centers, which can't really be general. You don't know if it can be generalized to other areas that have less access to care. The dose of the medications that was given may not be the correct effective dose for back pain. And the article actually talked about they don't really know what dose is, technically effective for back pain. So that was just the dose that they decided to use. And then they allowed the patient to self-titrate the muscle relaxers to see what dose they think would be helpful. As you remember, I said they could take 1 to 2 capsules of each of the muscle relaxers every 8 hours if needed. The occupations for the participants may have affected their back pain as well. Some people have a more rigorous jobs than others. And then they have baseline comorbidities. Maybe they have other more serious problems that we didn't know about. And they have their baseline physical activity as well. That was something that wasn't discussed in terms of how active they are on a daily basis. So another point is the discussion mainly for this article is that adding muscle relaxers to the ibuprofen does not seem to improve function or pain at 1 week after the emergency room visit for acute non-radicular low back pain. Similar studies came up with the same conclusion that adding muscle relaxers, diazepam, or opioids to NSAIDs does not seem to improve short or long-term function or pain. Unfortunately, a large number of patients will continue to have functional impairment and pain after 1 week of the ED visit. In this study in particular, about a third reported still severe pain at the 1 week follow-up. It's unclear if non-medical therapies combined with NSAIDs can help the acute low back pain. Non-medical therapies like physical therapy, heat pads, etc. So now I want to talk about acute low back pain so that we can apply this in our clinic here. For the residents, do you guys have any differentials for acute low back pain that you can think of?
Feel free to unmute or put in the chat box.
Just a muscle sprain?
Yeah, of course. Thank you.
Sciatica?
Yeah,
Someone put trauma.
yeah, of course. That's a good one. Yeah, so the differentials can be really wide for acute low back pain when we see them in the clinic. And this in no way is comprehensive of everything, but some way of thinking about it is this is based on the AFP journal article on acute low back pain that they broke it up into intrinsic spine, systemic, and referred pain. So intrinsic spine, you could have a compression fracture, herniated disc, lumbar strain or sprain, like Dr. Amati said, spondylo conditions, systemic, you could have inflammatory spondyloarthropathy, malignancy, vertebral discitis, osteomyelitis. You could have refer pain like abdominal aortic aneurysm, GI conditions, pancreatitis, peptic ulcer, cholecystitis, herpes, pelvic conditions like PID, retroperitoneal problems like colic, pilo, a whole host of things can be acute low back pain. But what's more important is you want to look for the red flags for serious etiologies of the low back pain to exclude, including, and again, this is from the AFP journal article table, could be cancer, cancer metastatic to the bone. You would have like maybe vertebral tenderness. You could have serious etiologies like cauda equina syndrome, when you have bowel bladder incontinence, urinary retention, progressive motor or sensory loss. And you could have major motor weakness, sensory deficit, loss of anal sphincter tone, saddle anesthesia. You could have a fracture, which is trauma. And it would be, for example, fall from a height or a motor vehicle crash in a young patient versus a minor fall in an older patient with osteoporosis. You could have an infection, like severe pain and lumbar spine surgery within the past year, fever, etc. So it's kind of important to kind of rule out these more serious etiologies before you treat them. Let's see. And so when I looked it up, the treatment for acute low back pain, first line is NSAIDs. You want to do a trial of 2 to 4 weeks. And the second line is addition of non-benzodiazepine muscle relaxers. Adverse effects, unfortunately, is sedation and dizziness, among others. So you want to be careful in the elderly when you add muscle relaxers. Opioids are generally not recommended, and you only want to use it when other pharmacotherapy is contraindicated or not helping. And you want to limit the opioids to a few days if possible. And Tylenol, unfortunately, is not recommended because it's been shown to have no benefit compared to placebo for acute low back pain. Non-pharmacological therapies, they have had the evidence for their effectiveness is like low to moderate. So using them is based on patient preference, cost, and individualized if they would like to try. Their evidence is, again, just low to moderate. So they can include things like heat, massage, acupuncture, spinal manipulation, exercise, physical therapy. And you want to refer people to physical therapy when they have risk factors for developing chronic low back pain, like people with poor functional or health status, with psychiatric comorbidities. things that you could add on at follow-up visits. So the summary of the presentation is that NSAIDs are the first line for acute low back pain. Unfortunately, NSAIDs is not necessarily appropriate for CKD patients, which make up a large portion of our patient population here at the FHC. So the results of these studies are limited to patient without CKD. So does the information in this article provide any improvement over what you currently do or learn? Since this is a POEMS, this is the point of doing it. So I think it did. So you want to treat with first line NSAIDs trial. You want to limit the muscle relaxers and opioids for the acute low back pain due to what we discussed earlier. Muscle relaxers not adding much more benefit to NSAIDs, and opioids, you want to limit those. And you want to stop using Tylenol because it's not effective for acute low back pain. And you refer to PT at follow-up visits when medications or non-pharmacologic methods don't work. And we're fortunate at our clinic to have a BHC that we can refer to for pain management, because unfortunately, like I said, a large number of patients will continue to have back pain, and their back pain will become a chronic back pain despite you doing the standard of care treatments. And these are my references to today. Does anyone have any questions?
Hey, yeah, I just thought of a question, Jasmine. Thank you for the presentation. I was wondering if this is kind of a general question, if anyone knew of any like discounted massage areas, or I don't think it's covered, like massages are covered by most insurances and probably not covered by whatever insurance our patients might have, because I do think that's a really good non-pharmacologic approach. But I mean, I think people view massages as very expensive. So besides encouraging my patients like to go on Groupon and see if there's anything, I was just wondering if anyone had any insights as to how to make those non-pharmacologic options seem more affordable for our patients.
I think that's a really great question. Thanks, Jasmine. I don't have an answer to that. I'm not sure if anyone has anything to contribute.
Jasmine, are you asking for acute low back pain?
Well, I guess like if it continues, like that's our next line or whatever, like for any acute or chronic. Personally, for me, massages help, but I feel like anytime I mention like the alternatives, people might write it off. So I'm just wondering if anyone has any insights into like if there's if it does something cover it that I don't know about, like are there vouchers?
Do you seem to remember we had a discussion about chronic low back pain? The best evidence I seem to remember is acupuncture. Correct me if
Even for that, I'm just wondering about economic like feasibility for our patients.
Gotcha.
Like even for that, is there like vouchers or something in the clinic? Has anyone heard about it? But the answer is probably no. I was just curious. But I'll just keep suggesting that because I do think that people, like our patients, would benefit from that rather than fighting with, you know, trying to limit the medication approaches and things like that.
Yeah, and I think you're right. There's probably a lot of resources for non-pharmacological therapies out there that we don't know about in terms of coverage, and maybe we can look more into that to provide resources for our patients here.
Hey, Dr. Nguyen, this is Byron Hepburn. You know, pre-COVID, we used to have the handouts in the clinic for the free pool therapy at the San Antonio Natatorium. I hope we still have those available. This is more for the chronic.
Oh, okay.
Yeah, that's a really a great asset we have here in San Antonio, and it is free. So
okay, thank you for letting us know that, Dr. Hepburn.
Well,
I'll look into it.
I'll check to see if it's still out there. I assume it still is, but that'd be another tool to put in your kit bag. But pool therapy definitely for more of the chronic.
Someone mentioned here in the comments that Arasti in San Antonio has a $5 clinic at their training center. So maybe There's also a question in here about what is recommended for patients with NSAID allergies.
I think at that point, then we can move down to our line of treatment. Like I said, I guess we could try the muscle relaxers, and then if not, we can go to the opioids. But we really want to try to limit those if we can, just because of all the adverse effects that come with it.
Anyone else have any comments? I see there are a couple of thank yous, just so you, I don't know if you're seeing your chat box.
I'm not. Thank you.
There's a great job, Claire. And a thank you as well.
Great job, Claire.
Thank you.
Thanks, Claire.
Okay, well, with that, I did put the link in there for everybody if you can help us out to give feedback to Dr. Nguyen. And other than that, I want to thank everybody for joining us, and thank you so much, Dr. Nguyen, for presenting today.
Thank you for everybody's time and your questions.